Hi there, welcome to another series in the CBH Pharmacy Revision series. We're going to be covering ACE inhibitors today and talking about the use of ACE inhibitors in clinical practice and obviously some of the things, the aspects that you have to watch out for in relation to this drug as well. Okay, so what are ACE inhibitors? ACE inhibitors are essentially used in hypertension, chronic heart failure, ischemic heart disease, and diabetic neuropathy with the presence of microalbuminuria. So one of the things here is I'd look up generally in the SPCs for the indications. Okay, so mechanism of action, basically it prevents the conversion of angiotensin 1 to angiotensin 2. And basically with that, angiotensin 2 is a vasoconstrictor which stimulates aldosterone secretion, and then blocking this lowers the blood pressure. Okay, now general side effects you find will be arrhythmias, asthenia, chest pain, constipation, cough, diarrhea, dizziness, drowsiness, dry mouth, dysphonia, and electrolyte imbalance. The two key things from here would be cough. So the reason why you get a dry cough is you get increased levels of bradykinin. And also with patients who have various comorbidities, you've got to look out for the electrolyte imbalance as well. Common drug interactions, any drugs that cause a risk of hyperkalemia. Now, obviously, patients who are managed with heart failure, for instance, will have drugs such as spironolactone. They'll be on drugs such as loop diuretics as well. And obviously, with here, you do get the specialist initiation first of all. So then, obviously, when that continues in primary care, we do tend to monitor the electrolytes. Okay, and then obviously some of the counterindications are a history of angioedema, renal artery stenosis, hypertensive or hemodynamically unstable states. One of the things I would advise here is looking in the individual SPCs about obviously the licensed indication for the drugs and the counterindication as well. Okay, so key concepts to help you with revision. One of the main things about revision with the ACE inhibitors is you'll get presented again with case studies, you may get presented with aspects such as questions around the side effects as well, and also relating this to the hypertension guidance as well. So obviously when you first give it for hypertension, it's best to take it at bedtime. The monitoring requirements is UNE. Okay, so patients must have a stable kidney function. And obviously when you initiate this medication, you do check the renal function 1 to 2 weeks later as well in clinical practice. With regards to ramipril, it's really, really important that anybody with a GFR of 30 to 60 mils per minute, they are only taking the maximum dose is 5 milligram. So it's really, really stress that kind of fact there as well. And you can get more information from this from the BNF and the SPC as well. Okay. We are going to be doing a series of further lectures, so please subscribe to our YouTube channel and thank you very much for listening.